So this was an interesting editorial by Dr. Deepak at the Brigham, a place where I also had the chance to train. And when and what to use when you're approaching a CTO. And here you can clearly see that if you have all the favorable factors, then there's really no requirement for using an additional imaging tool before you proceed. However, if you don't have these, that's when really the role of imaging comes in, and then that really helps the operator and makes the procedure successful and also short. And sometimes when we are young CTO operators, young in the curve of CTO, after the imaging, I think it would be a good idea when we realize that there is a highly complex lesion, for example, these patients need to be referred to a very experienced CTO center, and those have been already discussed before. So the challenges we know of CTO are many, and most important obviously is to fail to track your hardware through the occluded segment, and you need to have a map point. Now the evaluation of CTO from an imaging standpoint is that once you have a CTO, you need to look at the LV wall motion. If it is normal, then you need to go down and look at ischemia. As we know from the Courage trial, and also now the ischemia trial results are going to come out in January. For less than 10%, some of these patients are well managed by optical medical therapy. However, if you cross 10%, then these are patients that need to be really taken up, and the risk versus benefit ratio clearly is in favor of going and doing opening up the CTO. If the patient has an LV dysfunction which is significant, viability testing has to be done. And although we have had a couple of trials now which were really equivocal, but still, if you look at the data which is available, you need to have at least 10% of the myocardium subtended by the CTO to be viable before you proceed and get improvement in function. Now, if you look at CTA, I think we are far beyond the point where CTA is used just for calcium scoring or coronary anatomy. And you can see that there are multiple areas in which we are working right now with the cardiac CT. We don't call it a coronary CT anymore. And obviously, I'll be talking about evaluation of a CTO today. The CTA is a very versatile tool. You can look at perfusion here. During stress or rest, we use adenosine in our lab. You can look at CT FFR, and you can also look at the transluminal attenuation gradient, which is again a very important tool that we use when you're assessing CTO's antegrade versus retrograde approach. We all know the limitations of a traditional angiogram, the big problem about vessel overlap. Plaque characterization especially is a major problem in a routine angiogram. So CT does provide us some important advantages, the most important being plaque characterization, and you'll see that in the scores that I'll be showing you. And most important, it's a 3D picture, and the volume data can be infinitely manipulated, adjusted, turned, so that you get all the views in a single shot. And you know that CTA takes about 6 seconds to do. So this is the protocol, and I'm not going to spend too much time. Just to say, what we do in our lab is we give an extra triphasic injection. So normally just have a single contrast injection followed by saline, but what we do is we interpose a 30 to 40 ml of contrast and saline mix, so that really enhances the collaterals. Now, if you look at the angiogram versus CTA predictors, there's the JCTO score, which was talked to you about, and the CT rectus score, which I'll be talking to you about. You'll see that they are fairly equal in terms of what they can offer, what they can give to the operator, and also the easy versus difficulty is again very similar. This is a snapshot of how a CTO looks like on a CT, and you can see that you can look at the ostia, you can see whether this patient is good for an antegrade versus retrograde, you can look at the size, which French to use, and if you go down further, you can look at the lesion, the length of the lesion, the characterization of the lesion, positive remodeling. Further down, you can see that there's a calcified segment, and you can see that there's negative remodeling, and then at the junction, you can see again there's a calcified lesion. So the whole anatomy is really splayed out, and you can see that we have a whole lot of information that we can give when we analyze a CT. So looking at the data of the role of CT, you can see that the work started way back in 2005, and we are about 11 years from there. And starting from the 16 slice and now 64 and the 256 slice. The largest data had come out from Opolsky's lab, where he used a 128 slice scanner and looked at around 240 patients. And this was the data that was sort of put together by the German and the American groups, where they used CT and they came up with a score which was similar to the IJCTO score. And looking at it, you can see here that if you had a multiple occlusion, if you had a blunt stump, severe calcification, which was defined as greater than 50% of the lesion, or a bending more than 45 degrees, second attempt, or the duration of CTO longer than 12 months, then you would get the numbers here. And if your numbers were 0 to 1, as Dr. Dash had told you, then that would be an easy, relatively easy CTO to deal with. And if it was more than 3, that would be difficult. And these are just 2 examples I'm going to show you. You can see that this is an RCA CTO. It's short. When we look at the cross-section here, we get a nice cross-section on the CT, which is similar to IVUS. And you can see here there is absolutely no calcification. It is a soft plaque, non-calcified. If you look at the angle subtended by both the vessels, you can see that it is around 15 degrees, less than the 45 degree that we talked about. And I guess you will understand that the operator very easily passed it through the antegrade approach. Now look at this patient. Right from the ostium, there's a very long lesion. And most importantly, at the midpoint, there is a white area, which is calcification. If you look at the IVUS view, you can see that it occupies a large area, more than 50%. And if you look at the angle subtended by the 2 vessels, you can see that it is obviously more than 45 degrees. And this was obviously the result. The operators had to abandon the procedure. So very, very similar to the IJCTO, but using a non-invasive technique. And this is again an editorial by Dimitrios as to what further than the JCTO. And he also talked about wherein we could interpose CTA in evaluation of these patients with CTO. And what he did say was that if you have a patient with a very complex lesion and the dual angiography technique, which was again talked about, is still not giving you additional information, you have a very complex plaque, and calcium seems to be a major possibility, then CTA would be a very, very important tool to do it. Now, 2017, the KCCT came in, that is the Korean multi-center CTO trial. This was a registry data of more than about 450 patients and 4 big hospitals in South Korea. And they looked at CTOs and again came up with a very similar scoring system. The proximal entry site, the side branch presence, occlusion length here was 15 mm, not 20, which was there before, and a more than 45 degree bending angle. And they looked at calcification in an even more deeper manner, looking at more than 180 but less than 360 and 360 degrees, that is complete calcification, reattempt, and again occlusion duration, and again came up with a score. And when they looked at the score in those 450 odd patients, a few things really came up. 30 minutes is extremely high. The time taken is extremely low. The procedural time and the time to cross guide wire again is extremely high if you have 0 to 1, and it becomes extremely difficult and almost impossible to cross if you have a 7 to 8 scoring. And whether it was procedural success or the guide wire timing, again, there was a very good relation between the KCCT score as well as the outcome, final outcome. And I'll just leave you with some examples again. You can see here this is an LAD lesion. It's a short lesion. There's a rim of calcification here. And in the axial section again, you can see that is a small short segment. The dual angiography again confirms the same thing. And this patient had a good outcome. And this is another patient with a long lesion. You can see multiple calcific zones. The axial section shows almost 360 degrees. And the angiography again shows a very long lesion, more than 20 millimeters, showing very good correlation between the dual angiography versus CT. Again, this again an RCA CTO. There's no collateral seen on the angiogram, but when we did the CT, you can see that very favorable anatomy. The distal segment is very clearly marked, tapered segment, no side branch, and a short lesion. So I will just quickly run through how we sort of work with CT in these patients, and there are 6 important steps. The first step is first to just identify the CTO. So you can see the angiogram is done, you have an L6 lesion, complete occlusion, you've done the CT, and you can see the whole length played out. So identification, very important. You want to predict clinical benefit in these patients. You want to know whether this patient is going to improve. And this is our dual energy images from our own lab showing thinning as well as lack of perfusion in these areas, showing that there is a transmural scar in these patients and unlikely to recover. We also use PET in patients. You can see ostial LAD lesion, and there's a total occlusion. We did the PET scan, and then you can see here there's a significant perfusion defect in stress, complete normalization in rest in both images, and these are patients who will benefit with a CT opening. This is a patient with a left main lesion and an RCA total occlusion, and you can see in the PET scan we use adenosine in these patients. You can see there's a significant decreased perfusion in the right coronary territory and also in the LAD territory, complete normalization at rest, showing that these are patients who are good to take up. What is important now is with more than 64 slice PET scanners, you can get a very beautiful overlay of the arteries over the ischemic segment. And this is a patient, dual angiography showed a total occlusion. And you can see here that there is a decreased perfusion here, which normalizes at rest, showing that these lesions need to be opened and would benefit. Looking at procedural outcome, I just discussed the CT rectus score and the KCCT score. We look at the lesions, it's a long lesions. You look at all the variables that we have, the calcification, the bending angles, multiple occlusion sites, blunt stump, the occlusion length, and also we're looking at negative remodeling on the CT. The fifth thing that we look at is the pre-procedural planning, and this is a very important thing that we are trying to use and really helps the operator. So you get the data here, you can see that there's a long RCA segment. The images are loaded into a software. The TrueView software is one of the softwares that we use. It's a third-party software. And then you can actually roll around the entire image. You can rotate it. You can compare it to whichever angle you would like to use it when you're in the angiogram lab. And you get the whole artery splayed out. And you can also see the best views. So this is the angiogram of the same patient. This is a total occluded segment. Then we superimpose the CT pictures on that. The red cross is the point where we find that there's a complete CTO, and that is shown here on the CT angiogram right here. You can see the plaque location. You can see the type of plaque. There is a small eccentric calcification here. And then you can also measure the lesion length from the normal to normal. And you can assess, you can take the CT rectus score, and then finally when you are ready, you can also find the stent size, the positioning of the stent, distance from the branch, and the length. This is another patient where the LAD is looked at. You can see there's a total occlusion here on the angiogram. The CT images are loaded onto the software, and you get it registered using the center point line. The cross is again at the epicenter of the CTO. You can see here that this is the pathway, and then we can zoom in and see the type of CTO that is there, the calcification, beginning, end, the non-calcified area, the length of the lesion, all that can be assessed. And finally, when these patients come back, CT is a great tool to follow them up 6 months, 12 months. We have some 12-month data of some of our CTOs, which we do CTA. It's a non-invasive 5-second scan, and you can see very, very pristine images of the stents, and if there's any instant restenosis. Just a little word about stent follow-up, and we are looking at something like 90 to 92% if you're using a 128 slice scanner or above. The sensitivity and specificity is quite good. It's very important to know that we like to look at these stents if they are more than 3 millimeters in diameter and they're in the proximal location. CT is really not recommended for stents less than 3 mm or very distal. We have good algorithms that are available, and using the dual energy CT that we saw, wherein we can get viability, we can get perfusion, and we can get the follow-up. This is a new technique that we have used in a lab, and this is called the fly-through technique. It was actually developed for the colon, but we have adapted to use it for CTOs. And you can see here that this is a patient. We're just at the proximal part. This is the lesion. This is how it looks like. And you can see here the passage again becomes easy to see. This is when we're just right into the CTO. And the last image is when we are in the midpoint of the CTO. It becomes easy for us to visualize the entire passage, calcification intruding from outside, and the pathway. So the composite view of CTA, you can see here that you have a VRT image. We're showing the total occlusion, the LAD. You can have an axial image, proximal calcification, significant calcification, more than 50%. And by ablation of this calcium, the hardware could be guided through, and the final result was extremely good. So this is just to show the role of CT in sometimes very difficult situations it can be used. So in conclusion, ladies and gentlemen, CTA is a very highly sensitive tool. It's non-invasive. We use 50 to 60 ml of contrast. You don't need to do a dual angiography sometimes in these patients. It's not for a short unambiguous occluded segment with a high likelihood of success, both in the IJCTO score, but it's a great technique to use when you have a complex occlusion, the vessel trajectory is not good, the retrograde collaterals are not seen, and there is heavy calcification. Heavy calcification is something CT sees very exquisitely, and the kind of hardware you use and the additional techniques really makes a difference in this and makes life very easy for the operator and safe for the patient. Thank you very much.